Clinical judgment is the skill of recognizing cues regarding a clinical situation, generating and weighing hypotheses, taking action, and evaluating outcomes for the purpose of arriving at a satisfactory clinical outcome. Clinical judgment and the nursing process are closely aligned. They both guide nurses in making safe, effective decisions for patient care. The nursing process includes assessment, diagnosis, planning, implementation, and evaluation. Diagnosis stage is also now called the analysis stage. The clinical judgment measurement model breaks this down further into 6 cognitive steps: recognize cues, analyze cues, prioritize hypothesis, generate solutions, take action, and evaluate outcomes. Think of the clinical judgment measurement model as a more detailed version of the nursing process. For example, recognize and analyze cues is the equals assessment. Prioritize hypothesis is the diagnosis or analysis stage. Generate solutions is planning. Taking action is implementation. And evaluating outcomes is evaluation. The clinical judgment measurement model is used to measure how students think critically and respond to complex situations by focusing on how the decisions are made, not just what steps to follow. It's especially useful for preparing for the NCLEX in real-world clinical practice. Here on the slide, you see a picture of the National Council of State Boards of Nursing's clinical judgment measurement model, and you can see how it overlaps with the nursing process. Effective nursing care begins with the systematic and continuous collection, analysis, validation, and communication of patient data. This process helps nurses understand how a patient's health is either supported by wellness or is compromised by an illness or injury. The nursing database includes all relevant information gathered by nurses and other healthcare professionals, forms the foundation for clinical decision making and care planning. By using this database, nurses can partner with patients to create personalized, comprehensive, and effective care plans that reflect both medical needs and individual goals. Nursing assessments are not the same as medical assessments. Medical assessments focus on identifying pathologic conditions, the disease itself, while nursing assessments focus on patients' response to health problems, meaning how does the illness affect their ability to meet basic needs and perform daily activities? While nursing assessments may support medical diagnoses, their unique purpose is to understand the whole person, including physical, emotional, social, and spiritual needs. Always ask, how is this condition affecting the patient's life? That's a part of a nursing assessment. The nursing process begins and depends on accurate ongoing assessments. To assess effectively, nurses must use strong critical thinking, clinical reasoning, and clinical judgment skills. Key thinking activities during assessment include assessing systematically using nursing and medical frameworks, detecting bias and evaluating the credibility of the sources, distinguishing normal from abnormal findings and identifying risk, making judgments about what data is relevant and significant, identifying assumptions and inconsistencies, validating accuracy, and spotting any missing information. According to the ANA standards of practice, nurses must collect pertinent data relevant to the patient's health or situation. To do this well, assessments must reflect sound clinical reasoning. This is accomplished when assessments are purposeful, meaning that you know the type of assessment and why you're doing it, prioritize, with a focus on the most critical data first, complete, you've gathered enough information to fully understand the patient's condition, systematic, using a consistent method to avoid missing key details, factual and accurate, You avoid assumptions and validate all data. Relevant, record only what's meaningful and necessary. Standardize, you document clearly and consistency for team communication. So, a tip, describe what you observe, not what you interpret. For example, say patient refused lunch and ate only soup for dinner instead of patient is depressed. This keeps your documentation objective and useful for the entire care team. Nursing assessments come in several forms, each with a specific purpose and context. The initial assessment is performed at admission to establish a full health baseline. It guides the care planning and future assessments. A focused assessment targets a specific problem or symptom. It helps identify new or overlooked issues. Emergency assessments are conducted during crises, such as choking, bleeding, or unresponsiveness. It focuses on life-threatening conditions. A time-lapsed assessment is when you're able to compare current status to previous data. It's used in long-term or home care settings. And there is also a patient-centered assessment method. This one is where you will assess the complexity using social determinants of health, exploring lifestyle, environment, health literacy, and communication barriers. It helps tailor care to individual needs and improves outcomes. Assessment data are classified into two main types. Your subjective data, which is known only by the patient. It includes feelings, perceptions, and personal experiences. Examples of subjective data include pain, nausea, anxiety, or feeling cold. These are also called symptoms or covert data. The second type of data is your objective data. This is observable and measurable by others. This can be verified by multiple observers. Examples would be elevated temperature, moist skin, and refusal to eat. Also called signs of or overt data. Always combine both types of data to form a complete picture of the patient's condition. Subjective data gives insight into the patient's experience, while objective data provides measurable evidence for clinical decisions. Accurate nursing assessments rely on gathering data from multiple sources to build a complete picture of the patient's health. Key sources include patient, which is the primary and often most reliable source. Be mindful of communication barriers, emotional distress, or cognitive limitations. Always encourage direct input from the patient when possible. Another source of data are family and significant others. This one is useful when the patient is unable to communicate fully. Ensure consent and confidentiality when collecting data from support persons. Another source of data is the patient records. Review medical history, progress notes, lab results, and therapy reports. Use records to confirm, expand, or clarify data collected during assessment. Assessment technology is another source. Monitors and devices provide real-time data, such as vital sign monitors, cardiac activity. These types of sources support ongoing evaluation and decision-making. You can also use other healthcare professionals as sources of data. Collaborate with care team to understand patient habits, responses, and transitions. This is essential for continuity of care across settings. Other sources of data include nursing and healthcare literature. Use evidence-based resources to understand unfamiliar conditions. These type of sources support informed assessments and care planning. A key tip for students includes always verify data across sources, remain objective, and prioritize patient-centered communication. A well-rounded database leads to better care decisions and outcomes. Nurses collect data using two primary methods. the nursing history, and the physical assessment. These may be documented separately or combined into a single assessment form. A key skill in both methods is observation. This is the deliberate use of the five senses to gather meaningful data. Skilled nurses observe and interpret patient responses during every interaction. When observing, ask yourself, what are the patient's physical and emotional responses? Can the patient manage their care or do they need help? What environmental factors are relevant? Equipment, safety, people present? What's happening in the larger context, in the hospital or the community? A key tip is to train yourself to observe carefully and consistently. Observation is not passive, it's an active critical thinking skill that supports safe, person centered care. The nursing history is obtained through a patient interview, which is planned, purposeful conversation. Strong interviewing skills help nurses build trust and partnerships with the patient, show care and concern, and allow you to gather accurate and meaningful data. The interview has four phases. The preparatory phase, where you review patient information and prepare the environment. Your introduction, which is where you establish rapport and explain the purpose of the interview. The working phase, where you ask questions, listen actively, and collect the data. And then the termination phase, where you summarize key points and clarify the next steps. Remember that observation plays a key role throughout the interview. You want to watch for physical and emotional cues, environmental factors, and signs of distress. A physical assessment is the examination of the patient to gather objective data that helps define their condition and guide nursing care. This typically follows the nursing history and may confirm or reveal new information. Unlike medical assessments that focus on diagnosing disease, nursing physical assessments focus on the patient's functional abilities. This is how the illness affects their daily life and independence. Purposes of the nursing physical assessment include being able to appraise their health status, identify health problems, establish a database for nursing interventions. Settings and techniques will vary. For instance, in ICU, nurses use high-tech tools. Rehab nurses will focus on functional patterns. The assessment format usually follows a head-to-toe review of systems. Four key methods of data collection include inspection, which is a systematic visual observation, palpation, which is using touch to assess texture, temperature, moisture, and vibration. Percussion, which is tapping to produce sounds that reveal underlying structures. Auscultation, listening with a stethoscope to internal body sounds. Remember to focus on how the patient's condition affects their ability to function, not just what the condition is. This is the heart of what nursing assessments are. Accurate data collection is essential for safe and effective nursing care. However, several common issues can compromise the quality of your assessment. Common problems include poor organization of the database, omission of important data, inclusion of irrelevant or duplicate data, misinterpretation or recording of erroneous data, failure to build rapport with the patient, documenting interpretations instead of observed behaviors, and not updating the database as the patient's condition changes. Remember, stay systematic, objective, and patient-centered. Always verify questionable data, observe carefully, and update your records regularly to reflect the patient's current status. Validation is the act of confirming or verifying data to ensure it is accurate, unbiased, and correctly interpreted. It's a critical part of the assessment process because invalid data can lead to inappropriate care decisions. When do you validate? Discrepancies between what the patient says and what you observe. An example would be patient says, I'm fine, but appears tense and withdrawn. Another time that you would choose to validate is lack of objectivity. An example is you suspect hearing loss. You test it before documenting. When we validate, we first look to see that we perform physical examinations using proper equipment and procedures. We also validate by comparing the objective data from the physical exam to help verify patient reported symptoms, your subjective data. Another way we validate data is by using clarifying statements. We ask follow up questions to explore vague or conflicting information. For example, you say you feel fine, but your body language suggests otherwise. Can you tell me more? Another validation method is to share inferences with team members. When we do this, we are collaborating with other healthcare professionals to confirm observations. Team input can help validate or challenge your initial impressions. You may want to check findings with research reports. This is comparing your observation with evidence based literature. Ensure you use clinical guidelines to support or question your data. You can also compare cues to knowledge of normal function. Use your understanding of normal anatomy and physiology to interpret cues. Example, is that the patient's breathing pattern typical or concerning? And finally, check consistency of the cues. Look for patterns across different data sources. Consistent findings strengthen the reliability of your assessment. When it comes to documentation, clarity and accuracy are everything. The moment a patient is admitted, you start building their initial database, and that needs to be recorded the same day, whether it's in your computer or on paper, depending on your facility's protocol. Now, sometimes you're not going to be able to get all the information right away. That's okay, but make sure you note what's missing so it can be followed up quickly. Don't leave gaps in the record without explanation. As you document, think about how someone else, maybe another nurse or physician or a therapist, might read your notes. Will they get a clear picture of your patient? Your goal is to write in a way that comprehensive, concise, and it's easy to retrieve. Use proper grammar, legible handwriting if it's on paper, and stick to standard medical abbreviations. One of the best practices is to organize your notes under clear headings. That way, if anyone reviewing the chart will be able to find what they need without digging. And when you're recording subjective data, use the patient's own words whenever possible. For example, instead of summarizing, you'll write in quotations, I feel tired from the moment I first get up in the morning. It seems I have no energy at all. Quotation mark. If you paraphrase, be very specific. Patient reports feeling short of breath when walking up one flight of stairs. Avoid vague terms like normal, average, or poor. What's average to one nurse might mean something totally different to another. Be specific. Instead of saying fluid intake was good, say patient drank 1,200 milliliters of water and 300 milliliters of juice. In short, your documentation should tell the patient's story clearly and accurately. It's not just about checking boxes, it's about communicating everything that's going on. One of the most important responsibilities you have as a nurse is to protect your patient's privacy. When you're gathering data, whether it's through interviews, assessments, or observations, you'll often learn things that patients consider deeply personal, and they have every right to expect that you'll keep that information private. So, what does that look like in practice? If you walk into a room and the patient has family or friends present, don't just start asking questions. First, ask the patient if they're comfortable having others in the room. If not, politely ask them to step outside. This simple step shows respect and builds trust. Also, make sure you're familiar with your facility's privacy policies and the legal requirements under HIPAA. These aren't just rules, they're protections for your patients and for you as a professional. Let's talk about social media. It's tempting to share stories from clinical experiences, especially when they're powerful or emotional. Even if you don't mention names, sharing patient details online can cross ethical boundaries. Organizations like ANA, the NCSBN, and NSNA have clear guidelines about this. You can check their websites and stay informed. And as you all know, we have a social media policy as well. When you're preparing to assess a patient, you're not just collecting data, you're also deciding how to organize it. That's where clustering comes in. You might use Maslow's hierarchy of needs, Gordon's functional health patterns, or human response patterns. These are holistic models that help you see the patient as a whole person. Or if you're focusing on physical symptoms, you might use the body systems model, which is more medically oriented. Once you've chosen your framework, the next step is to start looking for patterns. What stands out? What seems connected? Alvaro Lefevre encourages nurses to test their first impressions. Don't just assume you know what's going on. Ask yourself, what's relevant? What might this data suggest? What else do I need to know to understand the full picture? And here's the key. Health problems are rarely caused by just one thing. There are usually multiple contributing factors. So part of your job is to figure out why the pattern exists, not just what it is. The flow chart of figure 1510 shows how this process unfolds. You start with assessment, collecting the data, identifying cues, validating what you find, and then clustering related information, and finally recording it. Then you move into clinical reasoning, where you analyze, synthesize, reflect, and make judgments. Finally, you're going to arrive at a diagnosis, a clear understanding of patients' problems that guide your care plan. This structured approach helps you move from raw data to meaningful insight, setting the stage for thoughtful, person centered care. Okay, we're moving on to chapter 16. We're going to be talking about analyzing cues, the identification of problems, and prioritization. And this aligns with the nursing process diagnosis or analysis. And here you see the clinical judgment measurement model, and you can see the overlapping of layer 3. That's where we have our clinical judgment measurement model. And then on the bottom, you have your nursing process, and you can see how it lines up. Once you've completed your assessment and gathered all the data, the next step is to diagnose, also called problem identification. This is where you start making sense of what you've learned about the patient. Diagnosing or analyzing isn't just about naming a condition. It's about understanding how the patient is responding to their health situation. You're looking at three things: how the person's responding physically, emotionally, socially to the actual potential health issue. You're also looking at what's causing or contributing to the problem. These are the etiologies. And you're also looking at what strengths or resources the patient has that can help them cope or recover. This phase, again, is sometimes called analysis. That's what we mostly refer to that this this stage now in the nursing process, because you are interpreting the data you've collected. You're identifying patterns, making connections, and deciding what needs attention. After you've completed your assessment, you reach a critical turning point in the nursing process. Again, diagnosis or analysis. This is where everything you've gathered, your observations, your patient interviews, physical assessments, and validated your data comes together. But diagnosis or analysis isn't just about naming a condition. It's about clarifying the exact nature of the problem and the risk that needs to be addressed, and then helping the patient reach their expected outcomes. If you don't fully understand what's going on or what's contributing to the issue, how can you plan effective care? And if you overlook risk, how can you prevent complications? This is the flow chart, figure 16-1, and it shows how this works. You start with assessment, collect the data, identify the cues, validate what you find, cluster related information, and test your first impressions. Then you move into clinical reasoning, where you analyze, synthesize, reflect, and draw conclusions. Finally, you arrive at diagnosis, where you create a list of suspected problems, ruling out similar ones, naming actual potential issues, identifying the causes and contributing factors, and recognizing risk and strengths. This phase is pivotal because the conclusion you make here shape the entire care plan. If your diagnosis is accurate and evidence-based, your plan will likely be effective. But if it's based on assumptions or incomplete reasoning, it could lead to poor outcomes or even harm. So you need to take your time. You need to think critically, use the data, and always ask yourself, do I truly understand what's happening with this patient? Nursing diagnosis or analysis is now recognized as an essential part of the nursing process, but it wasn't always that way. Early confusion with medical diagnosis caused controversy, but today the distinction is clear and critical. Medical diagnosis identifies a disease or condition like myocardial infarction and guides medical treatment, while nursing diagnosis or analysis is a clinical judgment about how a patient responds to health conditions like acute pain, anxiety, or activity intolerance and guides nursing care. Unlike medical diagnosis, which remain stable, nursing diagnosis can change daily as the patient's condition evolves. Nurses are vital members of the diagnostic team. As Gleason et al. Emphasize, nurses must be prepared to actively participate in the diagnostic process to help reduce diagnostic errors. For example, a patient with stress incontinence may receive nursing interventions like Kegel exercises and bladder training. A patient with cystitis benefits from early nurse-led detection and reporting, leading to timely medical treatment. A survivor of a sexual assault may need nursing diagnosis such as rape trauma response, coping impairment, and risk for infection. Bottom line, medical diagnosis treat diseases, while nursing diagnosis treat the person. And you, as the nurse, are accountable for the care that follows. You begin interpreting patient data the moment you start assessing. You're looking for significant cues, which is data that's going to raise those red flags and point to actual potential health problems. First up, recognizing significant data. This is where you're going to compare findings to the norms, age, race, illness category, and the patient's own baseline. You're going to look for changes in usual health patterns, any deviations from population norms, non-productive behaviors, and developmental lags. Next, you cluster the data. Don't diagnose from a single cue. You're going to use clusters of related data to identify patterns and form an accurate nursing diagnosis. Next, you'll identify strengths and problems. Strengths are healthy habits, coping skills, and support systems, while problems are areas where the patient doesn't meet health standards or lacks resources. Potential problems are trends that may lead to complications if not addressed. Remember, when identifying complications, you need to know the risks tied to diagnosis, treatments, and medications. Watch for early signs such as slurred speech, skin changes, alteration in consciousness, and report them immediately. When reaching conclusions, this is done after analyzing the data. The nurse reaches one of the three conclusions. The three conclusions include no problem, where no nursing action is needed. You're going to reinforce healthy habits, promote wellness and prevention, consider a wellness diagnosis if it's appropriate. Or they're going to come to the conclusion that it's a possible problem where more data is needed. This is where you'll need to continue assessing to confirm or rule out any issues. You also may come to the conclusion of an actual or potential problem. This is where you'll need to document the nursing diagnoses, begin planning and implementing care, collaborating with other healthcare professionals. And if the patient refuses care, ensure they understand the risk and the outcomes. Clinical problems other than nursing diagnosis may also occur at this time. This is the time to collaborate with a broader healthcare team. Key takeaway here is that your clinical judgment is going to drive your care plan. Whether confirming a diagnosis or promoting wellness, your decisions will shape patient outcomes. Next, we're moving on to Chapter 17, Generating Solutions, which aligns with outcome identification and planning. Here again, you can see the clinical judgment measurement model and where we are with level 3 and with the nursing process. The purpose of this step is in the nursing process is to establish clear, measurable outcomes and develop a care plan that's going to address the patient's identified problems, promote recovery, and support wellness. It requires critical thinking, collaboration, and a deep understanding of both patient priorities and clinical evidence. Clinical reasoning questions that will help you guide planning is one for setting priorities. You might ask which problems require immediate attention, which are my responsibility, and which should be referred. What matters most to the patient? The next questions are about identifying outcomes. What observable changes will indicate resolution? What's the expected time frame? Do the outcomes need to be adjusted based on the patient's response? Another area to consider are selecting evidence-based interventions. And the questions you might ask here are, what does nursing science and experience suggest will work? How can I tailor this intervention for this patient? What are the risks and how can I minimize them? When thinking about communicating the care plan, ask yourself, does the plan reflect today's priorities? Is it personalized for this patient? And will others know how to act on it effectively? A formal plan of care allows nurses to individualize care that maximizes outcome achievement, sets priorities, facilitates communication among nursing personnel and their colleagues, promotes continuity of high quality, cost effective care, coordinates care, evaluates the patient's responses to nursing care, creates a record that can be used for evaluation, research, reimbursement, and legal purposes. Also, it will promote the nurse's professional development. Here you see figure 17-1, a recap. The nurse and the patient working together to establish priorities, identifying expected outcomes, selecting evidence-based interventions, communicating the care plan, all while considering time, resources, and capabilities so that they are ensuring the plan is realistic, coordinated, and documented. When identifying outcomes in nursing interventions, nurses must apply standards from multiple sources. First, your state law. Your Nurse Practice Act is going to define your scope of practice and your responsibilities. We also have professional organizations. Groups like AACN or the ENA will set standards for specialty areas. The Joint Commission is an accreditation group that depends on meeting their detailed care standards. We also have the Agency for Healthcare Research and Quality, the AHRQ, which provides clinical guidance for prevention, diagnosis, and management. Your employer. The facilities have their own policy, procedures, and care pathways that guide nursing practice. Comprehensive planning can be broken down into 3 key stages. In acute care setting, planning is divided up in this way. Initial planning, the first stage of comprehensive planning. This is done by the nurse at admission using the nursing history and a physical assessment. The goal is to create a comprehensive care plan that will address each prioritized nursing diagnosis and set appropriate patient goals. To support this process, nurses often use standardized care plans. These are prepared plans based on common diagnoses and interventions for specific populations or conditions. They're available in textbooks, electronic health records, and facility developed pathways. Another element of the comprehensive planning is ongoing planning. This is continuous and carried out by any nurse who interacts with the patient. Its purpose is to keep the care plan current, manage risk factors, and promote optimal function. As new data comes in, you'll clarify existing nursing diagnoses, develop new ones if needed, adjust outcomes to be more realistic, and create new outcomes when necessary. Identify the most effective nursing interventions to meet the patient's goals. This process ensures that care remains responsive, personalized, and goal directed because patients change and so should the plan. Then you're going to include discharge planning. Discharge planning isn't something we save for the end. It begins at admission or even before, as we've discussed in previous lectures. It's best carried out by the nurse who knows the patient and the family well, often in collaboration with a social worker or a case manager. The goal, again, is to ensure the patient and family are prepared to manage their care at home. That means teaching them about their health condition, explaining the therapeutic regimen, building confidence and self care skills, connecting them with community resources. Effective discharge planning reduces readmissions, it improves their outcomes, and it empowers the patients to take charge of their own recovery. As future nurses, your ability to set priorities is not just a skill, it's a critical part of delivering safe, effective care. Clinical reasoning begins with asking four essential questions. What needs immediate attention and what are the risks if I wait? Sometimes the solution is simple. Reposition a patient to ease their breathing or make a quick call to a family member. Which problems are mine to solve and which require referral? Knowing your scope of practice is going to help you act confidently and collaborate wisely. Another question, can I use standard plans or protocols to address this issue? Tools like care pathways and standards of care will streamline decision making. Another question, what problems fall outside the protocols but still demand action for safe, high quality care? These are the moments where your judgment is truly going to make a difference and shine. Often patients have multiple problems or issues. A nurse would apply these questions to identify which of a patient's concerns require urgent attention, ensuring their care is both compassionate and clinically sound. Now, as you plan care, each day you're going to ask yourself, has the patient's condition changed? A new symptom or discovery like signs of elder abuse can shift your priorities instantly. If the patient's responding differently to an illness or the care plan, if this is occurring, um, such as if a patient who once welcomed counseling now asks for space, you must adapt your approach. Are there connections between problems that require sequencing? Some issues must be resolved before others can be addressed effectively. Can multiple problems be tackled together? Efficiency matters, but never at the cost of quality. You need to be thoughtful, ranking the problems, ensuring your time and energy go where they're needed most, toward the patient's most pressing needs. This is the heart of what clinical judgment is, and this is what nursing is. When planning patient care, it's important to distinguish between short term and long term outcomes. Short term outcomes are goals you expect to achieve within a few days, often during the current shift or even the hospital stay. While long term outcomes take more time, usually more than a week, and may even serve as a discharge goals. These are broader and help guide the entire nursing team toward the desired end result of care. Let's consider two patients. Both patients are 77 years old and recovering from hip fractures. One patient has been mostly bedbound in a long-term care facility for 2 years. The other patient swims daily and fractured her hip at the YMCA. Their short-term goals would include pain control or mobility assistance, which may be similar, but their long-term goals are going to differ significantly based on their baseline function and their lifestyle. That's why outcome planning must be individualized, even when the diagnoses are the same. When planning care, it's important to understand the type of change you're aiming for in your patient. Outcomes will fall into three categories. Cognitive outcomes. These reflect increases in knowledge or intellectual behaviors. For example, within one day, the patient will list three benefits of using moist compresses on her leg ulcer. Psychomotor outcomes are the ones that involve development of new skills. For example, the outcome may be by November 12th, the patient will correctly demonstrate how to apply a wet to dry dressing. Or the third category is affective outcomes. These describe changes in values, beliefs, or attitudes. An example of this might be by November 12th, the patient will verbalize valuing her health enough to practice new behaviors to prevent recurrence of the leg ulcer. Affective outcomes can be the most challenging to write and evaluate, but they're often the key to long-term success. Patient may understand the instructions and perform a skill, but without motivation, those behaviors may not stick. When writing patient outcomes, clarity and measurability are the key. Let's go over some common mistakes and how to fix them. First up, don't confuse an outcome with a nursing intervention. For example, offer Mr. Meyer 60 milliliters fluid every 2 hours is not an outcome. That would be an intervention. The correct way to write an outcome would be Mr. Meyer will drink 60 milliliters of fluid every 2 hours while awake, beginning 11/12/25. Next, use measurable, observable verbs. Incorrect way of writing it would be Mrs. Gaston will know how to bathe her newborn. You cannot measure, there's nothing measurable and observable about that outcome. The correct way would be to write it after attending the infant care class, Mrs. Gaston will correctly demonstrate newborn bathing. You also want to avoid vague verbs like know, understand, learn, or become aware. Avoid combining multiple behaviors in one short-term outcome. Incorrect way of writing it would be patient will list dangers of smoking and stop smoking. The correct way of writing this outcome would be by next meeting on November 12th, 25, patient will identify three dangers of smoking. By January 20th, 26, the patient will report that he no longer smokes. Be specific. Don't write vague outcomes. For example, patient will cope better. The correct way would be after teaching 11/20/25, patient will describe two coping strategies and show reduced ineffective behaviors like chain smoking or withdrawal. Planning care is essential to write outcomes that are patient-centered and measurable. This ensures clarity, accountability, and consistency across the care team. A well-written outcome includes a subject, usually the patient, a verb, the action the patient will perform, such as define, list, explain, verbalize, demonstrate, apply, choose, or describe. It'll include a condition, the circumstance under which the outcome will be achieved. This is optional but useful. Performance criteria, observable, measurable behavior. Target time, when the outcome should be achieved. An example of this would be during the next 24 hours, the patient's fluid intake will total at least 2,000 milliliters. Or at the next visit, on 12/23/25, the patient will correctly demonstrate relaxation exercises. And don't forget the SMART framework. S stands for specific, M for measurable, A for attainable, R for realistic, and T for time bound. This structure helps ensure your outcomes are clear, achievable, and focused on what matters most. the patient's progress. In planning care, nurses choose from three main types of interventions. Each are based on clinical judgment, collaboration, and patient needs. First, nurse-initiated interventions. These are independent. These are actions nurses take on their own based on scientific rationale and nursing knowledge. They do not require a provider's order or prescription. An example would include repositioning a patient, teaching self-care techniques, providing emotional support. These interventions are directly tied to the nursing diagnosis and analysis and aim to resolve or manage an identified problem. The next type of intervention are healthcare provider initiated interventions. These are dependent. These are treatments or actions that are carried out by the nurse but are ordered or prescribed by a physician or advanced practice provider. Some examples include administering prescribed medications, inserting a Foley catheter, starting IV fluids. The nurse is responsible for safely implementing these orders and monitoring the patient's response. And the third type of intervention are collaborative interventions. These involve working with other members of the healthcare team, like physical therapists, dietitians, social workers. Some examples include coordinating discharge planning, participating in interdisciplinary rounds, implementing a rehab plan. These interventions address complex patient needs that require shared expertise. A key takeaway here is that effective nursing care blends independent action, provider collaboration, and teamwork. Knowing which type of intervention to use and when is essential to safe patient-centered care. Here you see just a summary slide of some nurse-initiated interventions. Moving on to Chapter 18, taking action or the implementation phase of your nursing process. And here you can see in Layer 3, taking action of the clinical judgment measurement model and how it overlaps with the nursing process on the bottom, implementation. Now that you've carefully assessed, diagnosed, and planned, it's time to implement. This is where your evidence-based nursing actions are going to come to life. The goal is to help your patient achieve meaningful health outcomes, promote wellness, prevent illness, restore health, support coping with changes in function. Implementation is the most effective when patients are actively involved. They're able and willing, give them every opportunity to participate in their own care. Empowerment matters. And don't forget, family member support systems and your fellow healthcare professionals are key collaborators in this phase. As you carry out the plan, you're not just checking boxes, you're continuously observing, collecting new data, and adjusting the care plan as needed. Flexibility is going to be essential because patients change and so must your approach. Every action you take must be documented clearly and accurately using your facilities approved format. This is going to ensure continuity, accountability, and quality care. Want to see implementation in action? You need to check out the reflected practice box on page 476. This shows a powerful example of how a thoughtful nursing care makes a real difference. Remember, implementation is where your clinical judgment meets compassion. So it's also where plans become progress. As you step into a clinical setting, remember this. Implementation is not just doing, it's thinking, evaluating, and adapting in real time. Every nursing action you take should be guided by clinical reasoning and sound judgment. Patient conditions can shift in moments, so reassessment is not optional, it's essential. Before you ask yourself this: has anything changed? Is this still the best intervention? Does research support this approach? This is the heart of clinical inquiry, the ongoing process of questioning, evaluating, and improving your practice. Great nurses don't settle for routine. They ask, is there a better way to help my patient? And a golden rule teaches assess, reassess, revise, record. Assess before acting, reassess after each intervention, Revise your plan based on what you observe and record everything because documentation is accountability. You also need to know your limits. If you ever feel unsure about your ability, whether it's technical, cognitive, or interpersonal, you need to ask for help. It's not a weakness, it's professionalism, and it's your first responsibility because you're responsible to the patient. Nurses know that learning never stops. They lean on each other, share knowledge, and grow together. So as you implement care, do it with confidence, curiosity, and compassion. As the nurse, every action you take should be intentional, evidence based, and aimed at improving the patient's outcome. The nursing intervention classification defines a nursing intervention as any treatment based on clinical judgment and knowledge that a nurse performs to enhance the patient client outcome. These interventions are going to fall into several categories. First, direct care interventions. These are the ones that involve hands-on interaction with the patient, whether it's a physical care like wound dressing or psychosocial support like counseling. It's the human connection in nursing. Indirect care interventions are ones that happen behind the scenes but are just as vital, like coordinating care, managing the environment, or collaborating with other professionals. They support and amplify the effectiveness of direct care. Community public health interventions. These are ones that target populations, not just individuals. They focus on health promotion, disease prevention, and address broader social and political factors that influence health. Independent versus collaborative interventions. Independent interventions are nurse initiated based on your judgment and scope of practice, while collaborative interventions involve coordination with other healthcare providers, blending expertise for their best outcome. Here's just a summary slide for the guidelines. One, act in partnership with the patient and the family. Before implementing, reassess the patient to determine whether the action is still needed. Approach the patient competently and caringly, and modify any nursing interventions according to the patient's developmental and psychosocial background, their ability and willingness to participate in the care, and responses to previous nursing measures and progress toward the goal or outcome achievement. Few more guidelines. Check to make sure that the nursing interventions selected are consistent with standards of care and within legal and ethical guidelines to practice. Always question that the nursing intervention selected is the best of all possible alternatives. Develop a repertoire of skilled nursing interventions. The more options one can choose from, the greater the likelihood of success. Be sure that each nursing intervention is supported by sound scientific rationale as demanded by an evidence-based practice. Be sure that each nursing intervention is consistent with your professional standards of care and consistent with the protocols, policies, and procedures of the institution or agency. Be sure that the nursing actions are safe for this particular patient and individualized to the patient's preferences. And always clarify any questionable orders. Implementing involves carrying out the plan of care, which is modified in response to the patient changes. Numerous variables will influence the way the care plan is implemented. So see these arrows below, figure 18-1 from the textbook. As nurses, we pour our knowledge, compassion, and effort into creating care plans, but sometimes patients don't follow them. When that happens, it's not a moment for frustration, it's a moment for clinical reflection. First step is ask yourself why. Is the plan truly right for this patient? If not, the solution isn't to change the patient, it's to change the plan. But if the plan is sound, dig deeper. Common reasons for non-adherence include lack of family or emotional support, limited understanding of the benefits, low personal value placed on the outcome, physical or emotional side effects like pain or fatigue, financial barriers, or limited access to care. Your role is to identify and address these barriers, not to judge. Consider the difference between these two responses. First, what's wrong with you? Don't you know high blood pressure can kill you? The second response is, can you tell me why taking your medication as scheduled is so difficult for you? I'd really like to understand. In the first one, communication is shut down. In the second, communication is great. It opens the door to trust, insight, and better care. Remember, compassionate inquiry is a powerful clinical tool. When the patients struggle, your job is to understand, adapt, and advocate. Let's talk about the 5 rights of delegation. As nurses, delegation is a powerful tool, but only when it's done safely and thoughtfully. These 5 rights of delegation help ensure that every delegated task supports patient care and protects everyone involved. And I will say that these understanding how and when to delegate is on the NCLEX. It is something related to safe care of a patient. So it's very important that you understand and develop the skill of being able to delegate. First up, right task. The activity must fall within the delegatee's job description or be clearly outlined in your facility's policies and procedures. Competency training should be provided to ensure the delegatee is prepared. The right circumstance. Delegation is only appropriate when the patient's condition is stable. If anything changes, the delegatee must notify the licensed nurse immediately, who must reassess the situation. The next right is you must have the right person. The licensed nurse, the employer, and the delegatee share responsibility for ensuring the delegatee has the skills and knowledge to perform the task safely and effectively. The next right is the right directions and communication. Clear, specific instructions must be given. This includes what data they are to collect, how and when to report it, and any relevant patient details. The delegatee must understand and agree to the task and know they cannot make changes without consulting the nurse. The next right, or the last right, is to have the right supervision and evaluation. The licensed nurse must monitor, follow up, and evaluate the patient's response. The delegatee must communicate updates, and the nurse must be ready to intervene if needed. Documentation is essential. Delegation isn't just about handing off tasks, it's about building trust, ensuring safety, and supporting teamwork. Now we come to Chapter 19, evaluating outcomes or evaluation in the nursing process. And our final look at the clinical judgment measurement model. Layer 3, we're now on evaluating outcomes, and then down with the nursing process, we're on evaluation. In the 5th phase of the nursing process evaluation, you and your patient are going to work together to determine how well the care plan is working. This is where you're going to measure progress toward your expected outcomes that you've set during planning. The purpose of this evaluation is simple, but it's powerful to let your patient's response to care guide your next steps. And this is figure 19.1 in your textbook depicting evaluating. The nurse and the patient together measure how well the patient has achieved the outcomes specified in the plan of care. Factors that contribute to the patient's success or failure are identified, and then the plan of care is going to be modified if necessary. Patient responses to the plan of care determine whether the nursing care is to be continued as is, or modified, or even terminated. So, as we said, based on what you observed, you may decide to terminate the plan if all the goals are met, modify the plan if progress is limited or barriers arise, or you may continue the plan if more time is needed. But evaluation isn't just about checking results, it's about critical thinking. You'll identify what helped or hindered the patient's progress, and if changes are needed, you'll revisit every phase of the nursing process. by assessing, diagnosing, planning, and implementing. Successful evaluation ensures that care remains person centered, responsive, and effective. It also strengthens the public's trust in nursing and supports continued investment in nursing services. In nursing care, evaluation is more than just the final step. It's a continuous, thoughtful process that ensures our care is truly making the difference. The five classic elements of evaluation guide us in assessing whether our interventions are helping patients move toward their health goals. First, identify evaluative criteria and standards. You need to start by knowing what success looks like. These criteria are the expected patient outcomes you defined during the planning phase. They're your roadmap for measuring progress. The second element of is collect data. You gather information to determine whether those outcomes are being met. This includes observations, assessments, and patient feedback. The third element is interpret and summarize your findings. You're going to use clinical reasoning to make sense of the data. Are the outcomes being achieved? If not, why? What patterns or changes do you notice? Fourth element is you need to document your judgment, recording your evaluation clearly and accurately. Documentation ensures continuity of care and supports informed decision making. And the fifth element is terminate, continue, or modify the plan. Based on your findings, you're deciding whether to, again, terminate the plan if goals are met, continue if progress is steady, or modify the plan isn't working, or the patient needs have changed. Each step requires critical thinking, clinical judgment, and commitment to the person-centered care. Remember, it's not about checking boxes. It's about ensuring that every action that you are taking is going to lead to a meaningful, measurable outcome. When you're evaluating patient progress, you're looking at four distinct types of outcomes. Each reflect a different kind of change. The outcomes help us measure whether our care is truly making a difference. So we look at the cognitive outcomes. These reflect the increased knowledge or intellectual understanding to evaluate. We talked about cognitive outcomes before. This is asking the patient to repeat information or apply new knowledge. An example, within 1 day after teaching the patient, will list 3 benefits of continuing to apply moist compresses to the leg ulcer after discharge. This shows the patient understands the why behind the care. The psychomotor outcomes, these measures the patient's ability to perform new skills, evaluates asking patients to demonstrate the new skill. For example, by November 12th, 25, the patient will correctly demonstrate application of wet to dry dressing on the leg ulcer. This confirms the patient can do what is needed, and then the affective outcome. These were the ones involved in changing values, beliefs, and attitudes. And to evaluate this, you observe patient behavior and conversation. Again, by 11/12/25, the patient will verbalize valuing health sufficiently to practice new health behaviors to prevent recurrence of the leg ulcer. Even with knowledge and skill, motivation is the key to a lasting change. Physiologic outcomes, these are physical changes in the patient's health status, such as improved vital signs, wound healing, or reduced pain. To evaluate these, you use physical assessment skills to collect and compare the data. By 11/15/25, the patient's leg ulcer will show a 50% reduction in size and no signs of infection. This is tangible evidence of healing. Together, these four types of outcomes, cognitive, psychomotor, affective, and physiologic, give us a complete picture of patient progress, and they help us tailor the care, evaluate effectiveness, and ensure that our interventions are leading to meaningful, measurable results. So the evaluation isn't just about checking if the goal was met, but it's about understanding why. When we interpret and summarize findings, the nurse is going to need to consider variables that influence patient outcomes. These can come from the patient, the nurse, or the healthcare system, and they can either support or obstruct progress. Why this matters? Well, because by identifying these variables, nurses can reinforce positive factors for future success, address and adapt to negative influences, or deliver care that truly person-centered and responsive. Some positive influence include a patient who's motivated to learn, a nurse who brings fresh ideas and energy, or a facility that supports quality care with strong staffing and incentives. These factors can be leveraged to improve outcomes. For example, if a patient walks better when his wife is present, then schedule ambulation during her visits. If her presence causes fear, then adjust the plan and explore issue before discharge. Challenges to outcomes being achieved. There are also some patient variables related to this, such as refusal to cooperate due to emotional distress or distrust, or passive acceptance without self advocacy. Some nursing variables include burnout from overcommitment, personal stressors affecting their work performance, or boredom or lack of professional growth. Some system variables are inadequate staffing, unsupportive administration. Some creative nursing responses might be build trust and explore underlying patient concerns, educate passive patients to become assertive healthcare consumers, setting realistic expectations for yourself and seeking support, or advocating for better staffing and resources using data. If the system is unchangeable, consider a new practice setting. Successful evaluation means thinking critically, responding creatively, and always asking what's helping this patient succeed and what's standing in their way. This kind of thoughtful adaptive care not only is going to improve the outcome, it's going to elevate the profession of nursing. Our nursing care isn't complete until we've evaluated whether our goals have been met. This is where evaluative statements come in. They clearly communicate the patient's progress and guide next steps in care. Each evaluative statement should answer the simple question, has the patient met the expected outcome? So you have a goal statement, and an example would be beginning 11:08, the patient will ambulate half the length of the hallway with assistance 3 times a day. This is what you're aiming for. The evaluative statement would be documenting the result. So by 11:08, goal partially met, patient refused to ambulate in the morning but did walk to the bathroom once in the afternoon with the assistance of a nurse. The recommendation that would guide future care for this instance might be something like review reasons for progressive ambulation with the patient, assess motivation to increase independence. You would sign and date this, and then the statement would become part of the care plan. And it would ensure that the care remains dynamic, responsive, and patient centered. Remember, met means the goals were achieved, partially met means progress was made but not fully, and not met means the goal wasn't achieved and it's time to reassess. If the measured goals are not being met, meaning the patient shows little or no improvement toward the expected outcome, it's time to reassess and revise. You'll want to start by reviewing every step of the nursing process. Start with assessment. Do you need new data? Diagnosis analysis. Is the problem accurately defined? Planning. Are the goals realistic and meaningful? And then implementation. Were the interventions appropriate and effective? Once you've identified the barriers, you're going to use your evaluative statement to guide revisions. This may be something like this. Delete or modify the nursing diagnosis or problem. Maybe the issue isn't relevant or meaningful to the patient. Make the outcome statement more realistic. You might need to adjust based on the patient's current abilities, motivation, or preferences, or increase the complexity of the outcome. If the goal is met, step it up to promote continued progress. For example, from patient transfer from bed to chair to patient walks around the room with walker. You may need to adjust time criteria. Maybe the patient needs more time to adapt or respond, or change the nursing intervention. You may need to personalize the care by aligning the activities with the patient's interests or emotional needs. For example, the outcome may be that the resident will participate in 2 planned social activities per week beginning December the 16th. Modifying the care plan is a collaborative, thoughtful process. It ensures that the nursing care remains responsive, realistic, and again, patient centered because every patient deserves a plan that's going to work for them.